अस्सलाम वालेकुम वरहमतुल्लाह बिस्मिल्लाहिर्रहमानिर्रहीम नहमदुहु व नसल्ली अला रसूलिल करीम। मैं हूँ डॉक्टर जमाल ज़फ़र। मैं हूँ एक्स प्रोफेसर ऑफ मेडिसिन शहीद ज़ुल्फ़िकार अली मेडिकल यूनिवर्सिटी पिम्स इस्लामाबाद। आजकल मैं अपनी प्राइवेट प्रैक्टिस कर रहा हूँ। मेरा प्राइवेट छोटा सा क्लिनिक है, उसमें अपनी प्राइवेट प्रैक्टिस कर रहा हूँ। तो हमने बात करनी है डायबिटिक फुट के बारे में और ऑस्टियोमाइलिटिस के बारे में। तो इसको हम डिस्कस थोड़ा सा। डायबिटिक फुट इन्फेक्शन आपको पता है कि इट्स वेरी कॉमन एंड नाउ इट्स emerging problem, and as the prevalence of diabetes is increasing, diabetic foot infection and osteomyelitis is also on the rise. And when some gets osteomyelitis, it's a very bad news, and it is almost a certain amputation. So I think this is very important that we should be avoiding this complication, and if God forbid this complication arise, we should be very vigilant in treating this complication so that we get a good result and patient may not end up with amputation, and if it ends up with amputation, it should be very limited amputation. Save the limb because limbs are life. Because if you stand on one limb, how many minutes you can stand on one limb? So if you there is an amputation, it means the patient is standing on one limb. So it's very important. And neuropathy is one of the cause of this neuropathy and vasculopathy both can cause this. Neuropathy is due gives rise to sensory and motor neuropathy. When sensory neuropathy is there, patient can have painless trauma, patient can have bone changes, and patient can have deformities. Motor neuropathy also gives rise to muscle atrophy, and then when there are muscle weakness, then there is a flexibility of joints, and there is hyperextensibility of joint rather, and patient develops the deformities, and that lead to abnormal pressure, and then that abnormal pressure cause callosities, जिसको हम उर्दू में हम चंडी कहते हैं कि चंडियाँ बन गई हैं। वो कैलोसिटीज़ के साथ फिर कैलोसिटीज़ जब बर्स्ट करती हैं दैट लीव गिव राइज टू अल्सर। इसी तरीके से अल्सर के बाद देन देयर इज इन्फेक्शन इन द अल्सर, and as there is also autonomic neuropathy, and as you know, autonomic nerves are helpful in sweating, and when there is reduced sweating, then that leads to dry skin, and that also lead to infection. And autonomic neuropathy also has some vascular tone effect, and then when vascular effect goes away, and along with that painful trauma, and all these things lead to sharper joint, and that also later on gives rise to ulcer and infection. So this is a vicious circle. We have to break this vicious circle. And C fiber dysfunction is the most important thing which give rise to, these are large fiber and they are lost in cases of diabetic neuropathy. Loss of pain and warmth and thermal perception, loss of vibration, position sense is there, and position for position vibration sense you always use a tuning fork, and you should be having a tuning fork, you should be having a hammer, you should be having a pin, and also microfilament. And loss of pain and warm thermal perception later on lead to wasted intraossei. Patient can have hammer toe, patient can have claw toes, dry scaly feet, decreased blood flow is there, and also there is sometimes this lead to equinus deformities. Then bunion foots can also occur, warm feet, osteopenia, and increased blood flow. These all occur in neuropathy. And diabetic foot infection, in person with diabetic foot infection can destroy their foot and ruin their life in a remarkably short time. This is very important. अगर आप उस पाँव पे चलते रहें जहाँ ऑलरेडी इन्फेक्शन हो गई है, तो वो इस तरह है कि जिस तरह आप रोज़ाना ज़ख्म को छील रहे हैं, यानी दिस इज़ लाइक दैट कि आप जब प्रेशर डालते हैं तो जितना न्यूरोवेस्कुलर रिपेयर हुआ होता है दैट ऑल गेट डिस्ट्रॉयड, एंड पेशेंट is at the scale one next day. Sometime within just a few hours, this happens, and we describe a case of a patient with fulminating streptococcal group A infection who was apparently well at noon and very seriously ill 4 hours later, needing resuscitation and urgent treatment to save life. So this can happen. Patient can have septicemia, and patient can have the problems. So urgent and a very effective treatment is very important. Proper antibiotic, proper time, proper doses. I think these are the cornerstone of treatment along with the diabetic control. With diabetic patient, food patient with late infection are often an immediate danger of losing their life and limb. And usually the organisms are not single; they are polymicrobial, associated with deep food infection, and detail the meticulous care these patient needs. And that's very important that they should be not only be managed by physician, they should be the orthotics should be involved in that. Surgeon input should also be taken, and then proper footwear. All these things are important in managing the diabetic foot infection. So, types of foot infection, there are localized infection, and this is the initial stage. And at the start there is a small ulcer, and then it get deeper and deeper, and then there is spreading infection. Sepsis has progressed to give sign and spreading infection from the ulcers such as diffuse spreading erythema, edema, lymphangitis, and lymphadenitis. In addition, there will be usually be local sign of infection. ये this is very important और ये स्टेज जिसमें सेलुलाइटिस वगैरह हम बड़ा कॉमनली देखते हैं और आमतौर पे जब लेग्स में हो आप देखें यहाँ तो आमतौर पे सबकुटेनियस टिश्यू में फैट की वजह से एंटीबायोटिक की पेनिट्रेशन ब्लड वेसल सप्लाई कम होती है सबकुटेनियस फैट में तो उस वजह से एंटीबायोटिक की पेनिट्रेशन बड़ी पुअर होती है जिसकी वजह से इट टेक्स लॉन्ग टाइम टू heal that this simple cellulitis sometimes takes longer time to get better. Then there is severe infection. This refer to ulcer with extensive deep soft tissue infection and also infected feet with blue or purple discoloration of the tissue. And this stage usually a very life-threatening situation. So question is food deformity that lead to abnormal pressure points lead to the callus formation. Question two, this is important thing is this lead to callus formation. And question two, the dash are often in immediate danger of losing life and limb. That polymicrobial organism associated with deep wound infection. So diabetic foot patient with late infection are usually in a severe danger of losing their life and limb. And sepsis has progressed to give sign of spreading infection and emanating from the ulcer specify the type of infection और ये वही है कि जब अल्सर हो जाता है तो उसके बाद there is spreading of infection around in the surrounding tissue and deep in the bone and in the joints and that give rise to all these complications. Local signs that an ulcer has become infected include any of the following. Pain is one of the important symptoms, but sometimes in neuropathic ulcer it can be painless ulcer because there is no nerves, pain nerves are damaged, so it is painless. Base of the ulcer changes from healthy spin granulum to yellowish or grayish tissue, and this is one of these bad sign. And increased friability of the granulation tissue is one of the things which shows that the infection is spreading. Local signs that an ulcer has become infected include any of the following. So increased amount of exudate is one of the signs, and exudate changes from clear to purulent and unpleasant smell. Sometimes it's really foul smelling, anaerobic organisms are involved in that, and so these are the stages. Sometimes when initial stage is there is increased exudate, then this become purulent, and then there is smelly. And sinus develop in an ulcer, and edges may become undermined so that a probe can be passed under the skin. Pain as the sole manifestation of infection in a neuroischemic foot. This is a case that 77-year-old blind Afro-Caribbean man with type 2 diabetes of 22-year duration and peripheral vascular disease complained of pain in his right hallux and was brought to the foot clinic the same day. There was no swelling or cellulitis, but pain was exacerbating by gentle pressure on the nail plate, and a small area of nail plate close to the medial sulcus was very gently pared away to expose a small abscess under the nail, which was drained. A deep swab was sent for culture, and the abscess cavity was irrigated with normal saline and dressed with malolin and tuber gas, amoxicillin, clavin, and TDS, and flucloxacillin 500 milligram QID were prescribed. The wound swab grew Staphylococcal aureus and Streptococcus, and the toe healed in a month time. So sometime it happens that if you take urgent step, the things are very comforting and very gratifying. Pain may be the key point in the case one is the pain may be the sole manifestation of infection in the diabetic neuroischemic foot and is not always due to ischemia. However, in the presence of sufficient neuropathy, pain may be absent in the infective neuroischemic foot. Pain from infection under the nail is exacerbated by gentle pressure on the nail plate. This is very important. If you just press the nail, the pressure will be applied on the lateral side and that will give rise to pain. The podiatrist can achieve successful drainage of the infection without causing further trauma to the ischemic toe. Infection in the neuroischemic foot may not be associated with swelling. In the erythematous skin, wrinkles disappear, and where the infection is resolving, there is scaling. The portal of entry of infection may be a cone, callus, blister, fissure और any other skin break. ये important चीज़ें हैं कि इसमें कोई भी चीज़ जो सी है ना that can cause the site of entry of infection. जो तो छोटी सी एक आप कैलेसिटी को भी जो है ना इग्नोर नहीं कर सकते. So should be treated with systemic antibiotic. It can sometimes be treated with intramuscular antibiotic and bed rest as the patient's home under close surveillance by the relatives and frequent visit from the community nurse. पाकिस्तान में तो ऐसा कम्युनिटी नर्स का कोई कॉन्सेप्ट नहीं है तो यहाँ तो पेशेंट को हॉस्पिटल आना पड़ेगा या कोई ड्रेसर जो सा घर जाके पेशेंट का वूंड को वो ड्रेसिंग करेगा डेली एंड ही विल बी हैविंग क्लोज सर्वेलेंस ऑन दी diabetic infection. And this is another case in infection in a pregnant woman, a 32-year-old woman with type 1 diabetes of 19-year duration who was 28-week pregnant, noted a blister on the plantar aspect of the first toe associated with swelling and cellulitis. The blister was drained to reveal an ulcer, deep wound, swab grew staphylococcal aureus, streptococcus group B, and Cyanobacter. She had neuropathy but no ischemia. She was admitted and given intravenous ceftriaxone 1 gram daily and healed quickly. She was followed up in the diabetic foot clinic later on. Severe infection can also present as a bluish purple discoloration. और ये एक बैड साइन है जब इस तरह की पर्पल डिस्कशन हो तो इसमें कंपार्टमेंट सिंड्रोम बन जाते हैं जिसकी वजह से वेस्कुलर सप्लाई और फर्दर कंप्रोमाइज हो जाती है एंड पेशेंट इज लायबल टू एंड अप विद एम्पुटेशन. When there is inadequate supply of oxygen to the soft tissue, this is caused by increased metabolic demand of the infection and a restriction of blood flow in the skin. Secondary to septic vasculitis of the cutaneous circulation, purple blood may indicate subcutaneous necrosis. Blue discoloration can occur in both the neuropathic and also in the neuroischemic foot, particularly in the toes, and in the neuroischemic foot must not be automatically attributed to worsening ischemia. साइन ऑफ सीवियर इन्फेक्शन में इंक्लूड ड्रोजीनेस, शिवरिंग, टेकिकार्डिया, ये सारे सेप्टिसीमिया के सिस्टमिक सेप्टिसीमिया के साइंस हैं और हाइपोटेंशन, रिड्यूस बॉडी टेम्परेचर. सो दीज आर द साइन ऑफ सेप्टिसीमिया एंड दे बैड प्रोग्नोस्टिक साइंस. Osteomyelitis is an infection in the bone. Infection can reach a bone by traveling through the bloodstream or spreading from the nearby tissue. Infection can also begin in the bone itself if an injury exposes the bone to germs. So this is important. There are three routes. One, systemic infection, then local ulcer, later on giving rise to deep infection and go to bone, and the third is that bone itself get injured and then get infected. And X-ray and MRI are helpful in diagnosis of osteomyelitis and which may be confirmed in theory by a positive bone culture or bone biopsy showing bone death and inflammation and repair. So this is the picture of osteomyelitis. You can see in the X-ray also and ulcer on the surface of the bone having the osteomyelitis. So then you can go for the microbiological investigation in this patient. Ulcer is debride and surrounding callus and superficial slough. The ulcer is washed out with sterile normal saline. The base of the wound is then scraped with a scalpel blade and the scraping sent for culture without delay. If scraping is not possible, then deep swab is taken from the base of the ulcer. Laboratory investigation, blood should be taken for full blood count is very important. ये जो immediate investigation करनी चाहिए. Urea, creatinine, electrolytes, liver function test, C-reactive protein is important. And although the white cell count is only raised in 50% of the patient. Or radiological investigation में X-ray of the is very important, and when you are suspecting and you are not seeing anything on the X-ray, you can go for the MR to confirm the osteomyelitis. So sometimes you can see the gas in the gas forming organism which can give rise to gas gangrene, and you can see the gas in the soft tissue also. Another case, a male patient, 56-year, type 2 diabetes, duration of diabetes is 10 years, presented with wound on left foot plantar surface with discoloration of the second toe. History of unilateral swelling was not that was not present, and wound examined show the 4 foot area of 0.5 to 5 zero point 0.5 centimeter, zero point 0.5 depth was 1.5 centimeter and area was 0 0.5 into 0.5 centimeter. Temperature, it was a warm thing, warm microfilament and vibration sense absent. VPT right side 35 and VPT on left side was 35. Vascular pulse is not palpable. Pulse, pulses were palpable, and ABI was 1.2, which was in the normal range on both sides. And probe to bone was positive. So these are the scoring system of diabetic foot infection, uninfected, mild, moderate, and severe, and there are score for that. And diabetic foot ulcer classification of Sindh bath system is also there. You can always read it, and you should have that in your pocket so that you can always score the ulcer. So the message in the end is that you should get very much concerned when you see a patient with a superficial, simple superficial ulcer, and don't try to ignore it, and just don't miss the thing, because the time is the important factor. If you miss the time, the patient can end up with septicemia, patient can end up with osteomyelitis, and patient can end up with amputation of the foot, which is a very bad situation for the patient. Jazakumullah khair for the patient listening.